Dear students, we continue the psychiatry lectures. This is 5th year, first semester, and this is the 3rd lecture. Our today's topic are anxiety disorders. I would like to start with a great painting by Edvard Munch, the great expressionist painter, whose the title of this painting is Anxiety, and you can see in this strange, a little bit odd picture the expression of a kind of inner tension which reflects the subjective experience of anxiety. Anxiety has many symptoms, and basically 3 clusters can be differentiated. The first are the psychological symptoms as worry, fear, anticipation of misfortune, pessimism, irritability, tiredness, sleep disturbance, derealization, depersonalization, feelings. The other are the somatic symptoms as headache, dizziness, palpitation, chest pain, frequent urination, a kind of globe feeling in the throat, paresthesias, dry mouth, and you can see a list of these physical symptoms. And the third are the physical signs as cold, wet skin, tremor, hyperreflexia, tachycardia, or flushing. And all these 3 can appear together and are as expressions and symptoms of anxiety. In psychology, we differentiate fear from anxiety. Fear is a kind of fear from a real or imagined threat, which is a real and imagined threat, which connects to an emotional response, as anxiety is an anticipation of a threat concerning the future. So anxiety reflects on the future, and also anxiety sometimes is called fear from nothing, which is a good expression of this objectless inner tension. Anxiety disorders are most common psychiatric disorders. The prevalence is over 10%. There is a high comorbidity of anxiety disorders, which highlights the importance of the diagnosis and treatment of the disorders. For example, there is a high comorbidity with bipolar II depression, bipolar II affective disorder. Later we will learn that there are 2 types of bipolar illness, which was previously called manic depression. Bipolar I, when the patient has serious mania and serious depression, and bipolar II, when the patient has hypomania and serious depression. And with this bipolar II, there is a higher comorbidity of anxiety disorders. Unipolar major depression also many times common with anxiety disorders. Then addictological problems and suicidal behavior, especially panic disorder and social anxiety disorder, is many times comorbid with suicidality. There are high medical costs in anxiety disorders because there are many unnecessary examinations because of the physical symptoms, because of the physical signs, and sometimes exaggerated medication use can be identified in the case of many patients, because many patients use benzodiazepines very frequently, and benzodiazepine dependency can appear. Many anxiety disorders develop during childhood and persist in adulthood without treatment. Anxiety disorders are more prevalent among women. The ratio is 2 to 1. The background are the different endocrinological state of the female and the male, so the sexual steroids play a role in this higher prevalence of anxiety disorders among females, and the different stress response in males and females also form a background of this distribution. Genetic biological background is important, but we can mention here is the decreased activity of the serotonin transporter gene, which leads to increased stress response. These are the anxiety disorders in the recent classification systems in the DSM-5 and in the ICD-10 as panic disorder, agoraphobia, social anxiety disorder, specific phobias, generalized anxiety disorder, separation anxiety disorder, selective mutism, drug or medication-induced anxiety disorders, anxiety symptoms in general medical conditions, and mixed anxiety and depressive disorders, which also only appears in the ICD-10. This last diagnosis we cannot find in DSM-5. We will go through all of these and you will get a description of these disorders. Let's see first panic disorder, which means recurrent unexpected panic attacks. Typically a panic attack lasts from 5 minutes to 20 minutes. The panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time four or more of the following symptoms appears. The following symptoms, and these are the symptoms. So 4 is needed for the diagnosis of a panic attack from these 13. Palpitations, sweating, trembling, shaking, sensation of shortness of breath, feelings of choking, chest pain or discomfort. This can be a very alarming symptom because the clinician can think about acute myocardial infarct or angina, nausea or abdominal distress, feeling of dizziness, chills or heat sensations, paresthesias, derealization, feelings of unreality of the environment or depersonalization, which means that the patient feels that he had been changed, fear of losing control or going crazy, and fear of dying. So these are the third symptoms of anxiety disorders, and 4 is needed for the diagnosis. Also important to mention that we speak about panic disorder if there are 4 panic attacks or more during 1 month. So 1 panic attack is not panic disorder. It is said that nearly everybody had a panic attack during his or her life. We speak about panic disorder when there are 4 or more panic attacks during 1 month. So very important, the somatic differential diagnosis, acute myocardial infarct, angina, pectoris, pulmonary embolism, hyperthyroidism, can imitate many symptoms of a panic attack, gastric perforation, temporal lobe epilepsy, hyperglycemia, or caffeine intoxication. These all can be excluded before the clinician reaches the diagnosis of a panic attack or a panic disorder. The name of the panic disorder comes from Greek mythology. There was a Greek shepherd whose name was Pan, who lived in the hills. And when they were travelers, he jumped out and started to yell, and all the travelers became extremely excited. Pan was not dangerous for the travelers, but he very much frightened them, and this is why we speak about panic, that panic is not a real fear, it's not a life-threatening illness if somebody has a panic disorder, but it means a serious inner subjective fear from the patient. The prevalence of panic disorder is 2 to 4%. It's more common among women. Genetic, biological, psychological, and environmental causes play a role at the background. And you can see 2 data which reflects on the genetic background, that among 4 first-degree relatives there is a higher prevalence of panic disorder, and also among monozygotic twins the concordance rates are much higher than compared to dizygotic twins. The treatment, before the treatment, there are neurochemical etiology. There is a noradrenaline or norepinephrine hypothesis, which reflects on the role of the locus coeruleus overactivity. Also, there is a serotonin hypothesis of panic disorder, which is based by the effective treatment by SSRI, selective serotonin reuptake inhibitor antidepressants. Early separation from the mother, for example, during hospitalization in the early childhood period, can lead to a higher incidence of panic disorder much later. And object losses, which means the death of significant relatives, play a role in the etiology of panic disorder. If you are a clinician and you see a panic disorder, it's very much important to explore whether the patient had suffered from a death of a relative in the previous month or in the previous year. The treatment is listed here. Antidepressants, a different group of antidepressants can be mentioned. High potential benzodiazepines and alprazolam, clonazepam can be used, and different psychotherapy forms as cognitive behavior therapy, psychodynamic psychotherapy, for example, in object loss and death of a relative is the background of the panic disorder, and also relaxation treatment as ontogenic relaxation alternative training or other relaxation techniques are important. Agoraphobia is the next anxiety disorder. It's fear in places and situations where it is difficult to escape, and there is no immediate help in the event of a panic attack. Agoraphobia and panic are many times comorbid. The issue, the agoraphobia starts with certain panic attacks and build over the panic disorder. There is a diagnosis of panic disorder with agoraphobia. And the typical situation that the patient cannot go home alone, has fears and anxieties in crowd, cannot cross a bridge, cannot travel by bus or tram. According to the seriousness of the agoraphobia, we can differentiate mild, medium, and serious forms of agoraphobia. Mild do not really disturb normal lifestyle. In the most serious cases, there are almost a completely total staying at home, and the patient cannot leave the flat or the house of his. In the treatment of agoraphobia, behavior therapy is very important. Two techniques can be differentiated: systematic desensitization and flooding. Systematic desensitization means a gradual, step-by-step approaching of the feared place. For example, if somebody here in Page has an intensive agoraphobic fear from the arcade department store, because there are big crowd and it's a very big open space, then systematic desensitization means that step-by-step we approach the arcade. It can be done in relaxation or in hypnosis, or it can be done in vivo, that the therapist and the patient together walk first week towards the Zsolnay statue, next week toward the Konzum department store, and the third week they enter the arcade department store, and this is the systematic desensitization or gradual approaching of the feared object. The other technique is the flooding. Flooding, when somebody has a fear from traveling and you put the patient on an intercity train and he cannot take off, and it can have a direct and dramatic reducement of the anxiety which the patient first suffers from, but later this behavior technique can solve this kind of avoidant behavior which we see in the case of agoraphobia patients. The next illness is social anxiety disorder, which means a persistent fear of situations or actions where the person can be judged by perception or judgment of others. These patients cannot give a lecture. These patients has great problem introducing themselves in a crowd or in front of 10 or 15 people, and this makes serious anxiety. There is a subclinical form which is called a stage fright, which is not an illness, not a disease, but sometimes some people has to deal with this. Usually it begins under the age of 18, and it's more common among women. There is a danger of this illness, there is a risk of this problem, this social anxiety disorder, that patients can use alcohol or certain drugs to reduce anxiety, and it can lead to alcohol dependency or drug dependency. The treatment are also antidepressants, benzodiazepines, and different forms of psychotherapy. The next illness is specific phobia, which means fear from a special object, a persistent fear from a specific stimulation or object. The specific stimulus always provokes immediate anxiety response, and the subject avoids the object of the anxiety. For example, somebody has a serious phobic fear from a house, from a horse, or from a dog, or from spiders, which is called arachnophobia, or from sounders or lighting, which is called astrophobia. And this kind of fear seriously interferes with everyday functioning and reduces the patient's everyday adaptation to reality. Also, this illness often starts in childhood, and in some cases it eliminates, it disappears during early adulthood. In some other cases, this persists and needs treatment. There are two interesting small children who I need to mention here, and there is a so-called psychodynamic example, and there is a behavior learning theory example for the evaluation of specific phobia. The first is of a patient by Sigmund Freud, establisher of psychoanalysis. His name was Little Hans. Little Hans had a phobic fear from horses, and Freud developed a psychoanalysis with his child and with the father, and he wrote a big book on this. And it's a case report by Freud. And Freud found that with the exploration of the unconscious, it became clear that the fear from the horses was a replacement of Hans' fear from the father. So originally, Hans had an unconscious fear from the father, which was replaced, transferred on the horses, and this resulted the phobic symptom. Another, the learning theory explanation of phobias, because the learning theory explanation is that phobias are maladaptive learnings which are not needed, learning which were not needed. And this the case is a little Albert, who was a very small, 1-year-old child, who developed maladaptive learning mechanism during furry animals, and he started to fear from these animals, and later it was generalized, and he developed a whole kind of fear from everybody who was first, and later from Santa Claus he had a serious phobic fear. The treatment is psychotherapy and antidepressants and benzodiazepines, which should be used. The next illness is generalized anxiety disorder, which means an excessive anxiety and worry which occurs the previous 6 months, and it means a continuous anxiety. A panic disorder is a short panic attack, a short anxiety attack I have mentioned, which lasts from 5 minutes to 20 minutes. Generalized anxiety disorder lasts during the whole day. And it is more prevalent among women, and the prevalence rate is 2.5 to 6.4. And the risk also here is the development of alcohol dependence, because these patients many times try to reduce their continuous anxiety with the usage of alcohol, and also with the usage of benzodiazepines. They take more and more benzodiazepines to reduce inattention, which can lead to benzodiazepine dependency. The therapy is psychotherapy, antidepressants, and another type of anti-anxiety treatment can be introduced here, which is buspirone. You know that buspirone is not a benzodiazepine, but buspirone is a 5-HT1 partial agonist, which works on the serotonin system and cannot lead to increasing of tolerance and dependency. So this is why buspirone is a good alternative for benzodiazepine usage for the reducement of anxiety and antidepressants. What you have to know here that buspirone needs 2 to 3 weeks for the effect, which is the same in the case of antidepressants. As benzodiazepines works after 20 minutes, antidepressants and buspirone starts to have a clinical effect only after 2 or 3 weeks, and this is an important clinical knowledge. Separation anxiety disorder was previously was for the childhood period. Now it can be diagnosed at all ages, which means a developmentally inappropriate and excessive fear or anxiety concerning separation from those to whom the individual is attached. So separation from the mother, separation from the husband, separation from the wife can lead to these anxiety symptoms, and this is why it can be diagnosed recently in all ages and not only during childhood. The treatment is basically psychotherapy. Selective mutism, the child is not willing to communicate in the school, not willing to speak in the school, but at home communicates well with the parents, and this is what you can see here, it's more common among young children than adolescents. Previously, selective mutism was among the child psychiatric disorders and not in the anxiety disorders. Now it was put in the DSM-5 edition among the anxiety disorders, and what you see here that it's very important to separate this, differentiate it from autism, psychosis, language disorders and social anxiety disorders. The treatment is basically psychotherapy, and due to the fact that selective mutism patients has difficulties in speaking, not at home, many times non-verbal psychotherapies and music therapy or art therapy can be introduced to explore their unconscious contents, because patients cannot talk but can draw or can play music or can move in dance therapy, so non-verbal therapies are important here. Also we can mention drug and medication-induced anxiety disorders. Here you can see some cases of alcohol withdrawal. Alcohol withdrawal symptoms are many times very similar to anxiety attacks or anxiety symptoms, because patients in alcohol withdrawal has tremor, has tachycardia, has fatigue, has a little tension. Many times they have insomnia, they cannot sleep well. And all these symptoms can imitate an anxiety disorder symptomatology. But if we know that the patient is alcohol dependent and stopped drinking in the previous days, we can clinically think about that this is an alcohol withdrawal symptom with vegetative signs, and it's not an anxiety disorder. Caffeine intoxication above 250 milligrams caffeine usage, also important, because in some sensitive individuals a huge amount of caffeine intake can lead panic-like symptomatology, can lead to panic-like symptomatology. Cocaine and marijuana in some individuals also can cause anxiety disorders or anxiety symptoms. And sudden withdrawal of benzodiazepines as alcohol both have a GABAergic effect, and the withdrawal can lead to an increase of anxiety symptoms, and also the withdrawal of opiates can be mentioned here. There are anxiety symptoms in general medical conditions, which we have to mention, and I listed a few, as mitral valve prolapse syndrome, which is often associated with panic disorder, and also we know that MPS, mitral valve prolapse syndrome, is more common in panic disorder. So there is a comorbidity between the two. In acute myocardial infarction, in certain cardiomyopathies, the symptoms of anxiety can appear, and very important to know, as in the case of hyperglycemia, pheochromocytoma, and in hyperthyroidism. If you do the diagnosis of or differential diagnosis, you deal with the differential diagnosis of anxiety-like symptoms, it's very much important to exclude hyperthyroidism. So from the lab you should ask a TSH to exclude hyperthyroidism, because it can imitate panic disorder. And last but not least, there is the diagnosis of mixed anxiety and depressive disorder, which only can be found in ICD-10. So the previous ones you find in the DSM-5 and you find also in the ICD-10. This illness can be also only found in the ICD-10 International Classification of These Diseases, 10th edition. And this diagnosis means that these are mild cases where depressive and anxiety symptoms are present, but they do not fulfill the diagnostic criteria of a mood or an anxiety disorder. So the mild case do not fulfill the diagnosis criteria of a certain anxiety disorder, or the case do not fulfill the diagnostic criteria for dysthymia or persistent depressive disorder or major depression or seasonal affective disorder. Later we will learn these. So do not fulfill the criteria for mood disorder or bipolar II depression. But there are both mild anxiety and both mild depressive symptoms. They are together, they coexist, and then in this case this diagnosis can be given. The treatment is also pharmacotherapy and psychotherapy as a complex treatment in all anxiety disorders. And at the end of the lecture, I would like to show you another painting by Edvard Munch, The Scream, which is much more known and much more popular. And here also you can see the expressionistic exploration of a kind of inner frightening, which is a subjective experience of all patients who suffers from different forms of anxiety disorder. So I would like to thank you for your attention.